telephone.
Hi, this is Stan Dorn, working with Healthcare for All.
And I think Dr. Cook is going to join us at some point here. Okay. So we're expecting Dr. Cook on the phone. And I want to introduce David Romans, who is joining our HSCRC staff starting next week. And David, do you want to just give folks a little bit of your background who might not have met you? You wouldn't step up and take the microphone. We're not going to give you a break here.
Hi, David Romans. I've been with state government for 21 years now. The last 7 years as the Deputy Budget Secretary of the Department of Budget and Management. And prior to that, working with the General Assembly on healthcare finance and budget issues.
Thank you. And just quickly go around for the folks on the phone, just to announce who's here in the meeting. So, Paul, you're up.
Paul Parker, Maryland Healthcare Commission.
Dolly Mitra, Hilltop Institute.
Ben Steffen, Maryland Healthcare Commission.
Mike Robbins with the Maryland Hospital Association.
John Hamper with Care First.
Stu Gutterman with the Commonwealth Fund.
Ellen England, HSCRC. Shule Chillicole, HSCRC.
Jerry Schmidt, HSCRC.
Donna Kinzer, HSCRC.
John Falcomer, HSCRC consultant.
Jim McGee, Transit Employees Health and Welfare Fund.
Mary Jo Breed Forbes Health Research.
Thank you. We have a relatively full agenda today. We're going to change the order a little bit to accommodate some schedule issues, but we're going to start out with updates on two topics that we've been working on: the demographic adjustment, which we need to complete prior to our July 1 update, and also an update on the contract review process. We've been reviewing the global contracts, and to get a quick update on that. Then for accommodation of schedules, we'll probably go on to discuss the principles of for market share adjustments and the principles for guardrails, which are two things that the staff has prioritized to work on in the near term, and we wanted to start that process with a discussion of those items. Then we can move back to discuss near-term upcoming meetings and forming work groups to provide input to some of the tasks that we're going to be getting underway with in terms of market share and guardrails, et cetera. So with that, I'll let Shule give us an update on where we are with the demographic adjustment.
Can I have this? So we've been, I think we've been discussing the demographic adjustment in the past two meetings, and we apologize for the late documents, but there is nothing really new in them except the two things that I'm going to summarize at the end. But I also thought that I'd take this opportunity to explain the methodology in a little bit more detail so you all get the better understanding of what the exact calculations are. We drafted, some people are visual, some people like to read, so we have both, hopefully. I'll go through the PowerPoint, couple of slides in the PowerPoint, and if you have any comments on the document that we sent this morning, we would appreciate if you can help us to make that writing more understandable and kind of easy to follow. It's kind of the idea behind the demographic adjustment is, if you are under a global budget revenue, what should be your expected volume growth in normal circumstances because of population increases and aging of the population. And the third here is the efficiency adjustments, because given we have certain targets on an all-payer basis, when you do an age adjustment, the expectation is that the hospitals will realize some of the efficiencies, especially by reducing potentially avoidable utilization. Excuse me. So in terms of the way we calculate it, it's kind of looking at the geography. In this case, it's a zip code and age cohort, and looking at the market share of each hospital. So I don't want to confuse you with the big market share discussions we are having. So this is really looking at, in the base year, what was the proportion of volume that was provided by a hospital, and then assigning a population based on that number. So as an example, we have one hospital. We have, in this example, 2 hospitals and 2 zip codes. And you'll see that the hospital 1 has 70% of the volume in zip code A. And conversely, in zip code B, they have 40% of that volume. And in relation to this, hospital 1 is taking 70% of the population in zip code A into their base population. And in zip code B, they are getting 40% of the population in their base population. And on the demographic adjustment, then what we do is we take those base populations and then we inflate them based on the zip code age population growth provided by Claritas. And then at the end, we total them up and come up with a hospital population growth based on the distribution in each age and zip cohort.
Just a quick clarification. The population or the zip codes that you've picked up, is that 100% of the zip codes served by that hospital, or is it some different percent, 80%, 60%?
Good question. It's all the Maryland zip codes that are served by the hospital. So we didn't differentiate whether it is the primary or secondary, so it's all the zip codes. Since we are doing percentages, if they don't have a lot of patients coming, then they are not getting a lot of a population from that zip code and not any growth from that zip code.
I should know the answer to this, but the population you're referring to, are these the hospital-based admissions or outpatient volume? What's being decided to call something 70% versus 40?
So that's what we call the EC math calculation. It's the case mix adjusted inpatient discharges and equivalent outpatient discharges. So that's the volume.
I should have known that.
Equivalent case mix adjusted discharges, ECMADs, ECMADS. And in the description, we try to explain how it is calculated, but basically we look at case mix adjusted inpatient discharges. And on the outpatient side, since we don't have any corresponding number of discharges, we look at the average charge on the inpatient and convert that onto an outpatient discharge. So I can explain the details. I should say, if I can have a quick session at the end of the meeting if you want to go into the detail, and I can walk through the calculation with you. But this is a volume calculation, really, and then you look at the percent volume, and then here is your population based on that percent volume. And then, yeah.
Question. And the population growth is the projected population growth for the
Correct.
Year, right?
Mm-hmm. You'll see that in the current one, I didn't update, so there's some update I need to do. But right now, we are looking, for comparison purposes, we are looking at 2014 population growth. So that's the population growth side. And then what we are, maybe... So so that's the population growth side. Obviously, not everyone has the same expenditure profile. The aging weights are calculated so that if there is higher growth in an elderly population, you would expect the expenditures growth higher in those areas. So to accommodate that, we calculate the weights for age groups and then multiply those each population growth by this. So the same percentage of growth for 85 plus is weighted 3 times more compared to the average.
And one of the things that you updated were the number of weight categories. So this slide doesn't show the, oh, there you go.
And the slide that shows is number 13. So I'm skipping because we discussed the potential avoidable utilization in the prior meetings. So the changes from what we distributed in the first meeting is the work group looked at the age cohorts. Originally, we really didn't have much breakdown for the younger population. Looking at the data, and since these age groups have different trending, we broke down the younger population into more detailed subgroups. The subgroup also looked at the sex and race as other demographic factors. They do have different expenditure levels, but their growth rate are not that very different. So because of that reason, the work group, sub-work group suggested that we don't need to do more details, because as you try to do more detail, those percentages that we calculate at the zip code level becomes very unstable. So there is a threshold question, how far deep you want to go in these breakdowns on the demographic, how much you gain from that compared to the instability that you would have on the volume percent calculations. The other main changes from the first proposal was, if you remember, we were doing age-adjusted weights, and then we were doing a PAU at the statewide level, reducing those weights. The work group, based on the work group discussions and feedback, what we are now doing is we are basing the PAU adjustments at the end on a hospital-specific percent PAU. So I'm going to explain that to you in just a little bit with the data chart that I have. And lastly, we had another adjustment. Once we took out the PAUs, we were also scaling for 50-50 variable cost factor. Instead of doing 50-50 variable cost factor, now the adjustment is to make sure that you get to the statewide average. Let me talk from the data so you can understand those two, because it probably makes sense to do it with the data. So if you take the data sheet that we had, and those who are participating online, this is an Excel sheet, and I think it's the third sheet that we have. So in this sheet, you have the hospital name and hospital number. And here you see I put the EC mass here so you can see the total volume of each hospital. And I apologize, it's probably quite small. But in general, so let's take the first hospital, Meritus. They have 21,000 EC mass, and their assigned population is 115 people. 115,000 people. And what we do is then we calculate the population growth for these zip and age groups, and without any adjustment, the hospital's population is projected to grow by 0.46%. And when you apply the age weights, which are statewide weights, which were, let me go back to that one, on slide 8, the Meritus population or volume growth is supposed to be at 1.12%. So that's the impact of Meritus having higher growth rates in the elderly. Everyone is with me so far? Then we had two adjustments. The first one is the PAU adjustment. Initially, what we were doing is every age cohort had the same percent adjustment. So it wasn't dependent on the hospital's percentage, but it was a statewide reduction on the age weights to lower the age-adjusted growth rate. Now, the new proposal is to use the hospital's percent revenue in potentially avoidable utilization. So for Meritus, it's 17%. So we reduced the age-adjusted growth rate by 17% first. So the growth now comes down to 0.92%. If a hospital has higher PAUs, their reduction is obviously higher. If they have lower PAUs, their reduction would be lower. The critique of the old method was that you're using a statewide reduction. It's the same for each age group. So there was a confusion about how the hospital performance impact these reductions, because it was depending on from the hospital perspective, it didn't depend on their PAU performance. It depended on the type of patients that they were serving. If they had more elderly, we were reducing them more because our age-adjusted weights were much lower. Rather than doing that statewide age-specific one, now hospital can clearly see that they have 17% PAUs and their allowed volume is reduced by 17%. All right. Any questions on this one? So if you look at the final column for the PAU and age-adjusted growth for 2014, the statewide, we are at 1.1% overall volume growth. If I go back a little bit, so without any adjustment, the population growth is 0.59%. When you use the age adjustment, it goes up to 1.31%. And when you reduce it by 14% PAUs, we are now at 1.1% PAU and age-adjusted volume growth. In our all-payer model, our population is not age-adjusted. We are expected to gain enough efficiencies to finance the aging of the population. So we have an issue here that our model allows only 0.7. That's the Department of Planning population growth, 0.7. And with the adjustment, even when we take out the PAUs, we are still above that allowed amount. The blue column next to it is scaled age and PAU adjusted growth. So what we did here is, again, different from the earlier one. We reduced the final PAU adjusted one by the same amount for each hospital so that statewide we get to our target of 0.6%. Previously, we were using 50-50 variable cost factor, so we were taking half of the adjusted ones, and right now we are making sure that we hit the 0.6, and that is equal to 55% of the allowed amount. And you see in the last three columns the previous old age categories and 50-50 adjustment, and the difference column is the new methodology versus the old methodology. So basically the changes we made didn't make much impact if you look at the final difference column. They are all less than 1%. It just refined it and made it more hospital specific, so it's hopefully more clear to the hospitals. If they reduce their PAU, next year their PAU adjustment on their volume is going to be much smaller than they did today. And the second enhancement is that we make sure that we have a target of 0.6 in the table for the total volume growth. So we are making sure that whatever distribution we calculate, we do not exceed our target for the overall volume growth.
Just a quick question. You mentioned 0.71 was population, and it's been reduced to 0.6. Not that it's a huge difference, but is there a reason why it was scaled down to 0.7 to 0.6?
I'm glad you asked that, Mr. Craney. Well, the major academic medical institutions that have quaternary care are having categorical cases that are on a separate budget that have some actual adjustments on a going forward basis, and we're working with the transfers in, and so there's a little bit of give there just to make sure that we're covered on other volumes that might be above the 0.6 as we make round the corner on the transition and get those methodologies clearly in place and locked down. But there has been some growth also in the in some of the transplant cases and some of the other categorical cases. So we're evaluating that, and we'll have a better picture of it as we go along.
So what I understand you're doing is because that population growth is in more expensive categories, that is why we have a lower population target. Am I understanding that correctly? In a kind of, put it in simple terms?
The population growth that's allowed in the calculation is 0.1, but we've put 0.71, but we've put 0.6 in through this calculation because we think there could be a little bit of volume growth recognized outside of the formula. And there are still a couple hospitals who haven't finished their global budget, so there could be a couple hospitals that have volume growth outside of global budget. So there's a 0.1% difference that's being held to the side to cover expensive cases that were having some adjustments on the annual budget instead of while they're on a global budget, they are adjusted for actual experience in terms of growth on an annual basis. So we're keeping some money to the side to make sure that there's adequate funds for those issues.
So I think I know it's hard for me to decide what level you guys need information. It's really hard to keep it at the medium. You either have to go deep or stay high. I would we have a high. So first thing is, if you have any comments, if you could send it to me by this Friday. And if you would like to get together and kind of dig deep into some of these numbers, I'll be happy to do that as well. So we can set up a time by phone or in person to work through these. But I think Friday is kind of our approximate deadline so that I can go back and revise these numbers and update them with the 2015 and kind of keep this as final for the 2015 GBR contracts. And hope, we'll continue to work on it as we go along for future years. Is that right, right assessment, right?
Yes, we need to get any final comments in because we need to actually do the calculation so that we can, we're due to have budget updates effective July 1, so we need to complete the population adjustment so that we can incorporate that into the July 1 update. Are there other comments or questions before we?
Just a request, if you do set up a call, if you get a request for a call, I'm not asking you for a call, but if you have a call, can you let the rest of us know so that if we, so that we know and then we can call in?
Absolutely.
Yeah, and this may be actually the last bullet point on your screen here. There were two hospitals in here that I think when the demographic subgroup looked at this that ended up with a negative number, and there was discussion about limiting that to 0 instead of having a negative volume adjustment? Is that still part of your consideration here?
That's right. Thank you. I skipped that one. So as Mike said, there are 2 hospitals, and since global budgets are supposed to keep the revenue stable, we do not want to make any negative adjustment, even in the demographic adjustment. So if they have negative results, their adjustment is going to be 0.
So a lot of hospitals don't have organized pediatric units. So, you know, they would have pediatric patients coming in through their emergency department. And they would have service areas that obviously include 0 to 14 age group. But hospitals that have pediatric units, they would have a different revenue picture from that age group because they've got, you know, inpatient revenue coming in as well. And actually, if you look at pediatrics, it's very concentrated in Maryland. It's like 70% of the pediatric discharges are literally, I think, 4 or 5 hospitals.
Mm-hmm.
So does that get taken care of through the ECMEDs? Have you looked at that?
Yeah, so the age group that we have is the, if I go back to 0-4, it's here, right, and 5-14, and some 15 to 44. But if the hospital has a pediatric unit, their market share from the zip code is going to be much higher. So they're going to get more younger population into their population. And as that age group is growing faster, let's assume, then they're going to have faster growth in their base. If that age group is growing slower, then their expected volume is going to be much smaller.
So the answer is yes,
yes.
it's taken care of.
Okay. I guess that would apply to perinatal services as well, because there's also hospitals that don't really, they miss on the inpatient side quite a few younger women because they aren't coming into the hospital to deliver babies. But I guess you obviously have a much larger market share if you're a hospital that has a perinatal service.
That's right. And that's why we broke out. If you look at the earlier breakdown, it was from 15 to 64. So we separated into so that we picked child age bearing 15 to 44 more in more detail. So that kind of reflects in your market share a little bit better if we break that age group into 2 groups. We considered doing, a gender-specific one, but it wasn't worth the squeeze because the growth in females versus males is the same. Even though you have a difference in the base, your growth rates are the same, so you end up having the same overall total at the end. So the breakdown of the age, we think, kind of captured some of the prenatal services by inflating the market share of those hospitals in a given geography.
Other questions?
There is one online from Charles Wieland, and he's asking, is the percentage change in the blue column effectively the percentage change in expected EC mats for a given hospital? So the blue columns are the final results. So here I'm comparing the new methodology to the old methodology, which we used for fiscal year 14. So it's kind of the blue column at the end is allowed volume growth for each hospital, if it makes any sense. If not, I'll catch up with him after the meeting. Okay, thanks. All right. Okay, so I'm expecting some feedback, and I'll see if I can schedule something if you wish to.
Okay. So the next topic is the review of global budget contracts. we've had a subgroup that has been reviewing the contract terms, and we've been reviewing both the GBR contract as well as the TPR contract. I think in general there are many similarities between the contracts because the GBR contract or agreement started with the TPR agreement as its base. So it wasn't surprising to find that many of the provisions were similar or exactly the same. I think that as a result of going through what I've tried to do in and you have a document called Review of Global Budget Contracts. I've tried to summarize what I think the results were from those meetings with the work group and sub-work group, and we'll certainly ask anybody to speak if they have a different concept from that process. But at the conclusion, I think there's a sense that it would be good to move to a single agreement document, recognizing that some of the terms might still be unique for the total patient revenue hospitals, but that much of the contract detail really should be identical between the two types of agreements. And in particular, when we wrote the GBR agreement, we took we had focused on adding in some consumer protections, if you will, and consumer-friendly language into the new or into the GBR agreement. And we would want to make sure that as we redraft the agreements that that those be consistent across the entire all of the hospitals. That being said, we think that it would be a good aim to have a new standard agreement in place for fiscal year 2016, which would give us an opportunity to get the agreement redrafted and reviewed and sent out to signed, et cetera, and so forth. There are some more immediate concerns, if you will, or issues that need to be addressed. One is that there are reporting templates that are required for the agreements, and we'll need to move forward with that and appoint some subgroups to work on those reporting templates. One is for contract compliance or agreement compliance and monitoring, and the other is for reporting on infrastructure investments. So what investments did the hospital make in infrastructure, and what were the results of those investments? So that's one area that will need to be addressed more immediately. The second area relates to underages and overages, if you will, in terms of charges. When the hospital charges under the agreement, they may end up with an undercharge or an overcharge relative to their global budget. And the GBR agreement has a 40% penalty on both underages or overages above a 0.5% variation. Some folks thought this was a little tight in terms of the penalty corridor, and also the HSCRC staff doesn't want to carry forward undercharges of any magnitude from year to year. So in other words, if you didn't charge it, then we don't want you to be able to charge it next year because it frustrates our ability to plan and budget for the model. So we discussed the possibility of some different corridors, we can they're listed in the table below relative to overages of a 0.2% penalty, and actually I think I have repeated that 0.4% penalty again. But the above the 0.5%, that's what you get for too many late nights. But above the 0.5% up to 1%, we were focused on a 0.2% penalty, and then above that of going to a stiffer penalty. So I think we were trying to ease that penalty a little bit between, so I will correct that, but ease the penalty a little bit from 0.5 to 0.1. If people aren't getting pretty close, we'll tighten it back down, but because we really do need compliance. And then above 1%, a 50% penalty for overages. On the underage side, again, the 0.2% penalty from 0.5 to 0.1%, 1 to 2 at 50%, and beyond 2%, no carryover. So there's not a penalty to the permanent revenue, but the proposal is that we're not focused on carrying over undercharges below 2%. I'm sorry.
That table, I'm just want to make sure that I'm reading this right. The bottom half of that table, the 0.5 to 1%, should that be under?
Yes.
Okay.
So they should both be under. So
okay.
So we'll get those fixed to below. Thank you. So right. So below on the two there. Thank you. So basically, if you overcharge, you pay that back, and a 50% penalty if the overcharge is more than 1%, because we really don't want overcharges in the new system. We want to discourage them. So we'll let folks don't have to make final comments on that today, but if people want to comment on it, that's great, or you can continue to digest it a little bit. And
I actually just had one clarification. This is when we measure their compliance at the end of the year, not on an interim or quarterly basis, that these penalties would be applied would be at the end of the year.
This is an end-of-the-year calculation. We are going to also discuss targets at December 31 because we can't have folks overcharged at December 31. It's not an acceptable situation. So we are going to actually put targets into the contracts, into the agreements. Right now, we're not focused on putting penalties on the targets because, you know, we're going to focus on compliance, and if folks comply, then we'll leave it without a penalty situation. But if they don't, then we'll adjust the policy as necessary. But we will monitor it, and we will. And folks will need to agree to those targets.
I just have a clarification. Maybe this is obvious, but when you use the term underage and overage, are you speaking of revenue that the hospital generates?
Yes.
Okay. And not differences between revenue and expense?
No.
Okay. I just want to be clear on that. I mean, that's what I thought, but I wanted to make sure.
We'll try to make it clear in the way it's written up, as it's not always clear. We didn't call them overcharges and undercharges either, because that kind of gets confusing with rates, because it's really related to a budget. David?
Donna, for the calendar year, when you get into the targets, I think we're going to have to watch what happened in the last 6 months of this fiscal year as the rate orders came in after the fact. There might be some one-time catching up or undercharges that have occurred that will skew that 12-month number through December.
We're right. I think we can actually, we are most likely going to ask folks to take care of their underages or overages before December when we build the December target. If they're, it depends.
I guess what I'm saying.
We'll look at the circumstances.
Yeah, I guess what I'm saying is in the last 6 months of this fiscal year, somebody had to overcharge. I don't have this at one of my hospitals. I'm just thinking here hypothetically. Somebody had to overcharge 4% in that 6-month period to get into compliance with their 12-month rate order. That might cause an issue for a 12-month compliance from January 1 through December. And since the rate orders came late, you could see
limit the amount of cross-subsidization that could be put in place by overcharging in one area and undercharging in another area, and doing that repeatedly and consistently. And so by putting limits on that, we're focused on limiting the ability to shift charges across payers or services. And the contract also states that the hospitals are supposed to spread their overages and underages ratably, and staff is on the lookout for that. So those are one reason for the policy, and so if I harken back to my younger years, hospitals used to undercharge on OB because it was a competitive service, and so this policy would keep a hospital from undercharging on OB by a lot and overcharging somewhere else repeatedly to make up for it, for example. So that's one purpose of the policy, and we're not really interested in changing any of that purpose. The second thing is that the HSCRC staff wants the opportunity to review large volume decreases and make sure that those volume decreases are not resulting from market share shift or stopping to provide services. So, one of the what we're proposing in this regard is that that the staff should draft a policy to indicate that if someone does want to breach the 10% corridor, that they'll need to have their have the HSCRC staff in the hospital look at the volume trends and the reasons for the volume reductions and adequately address the reason for volume reductions and make sure that that all parties are comfortable that we've accounted for any market share shift or any shifting of services to unregulated settings or reductions in services being provided before allowing that corridor to be breached, if you will. And also that we should have a review to determine what is going to happen after that 10%. So if volumes have fallen by 10%, have the operating costs been addressed? What additional investments beyond the 10% are going to be needed, and what are the hospital's plans for taking it to the next level in terms of investments in population health care improvement, physician alignment activities, et cetera, and any savings that aren't being used for those activities that would be taken in the form of a lower update or a shared savings calculation beyond that 10% level. So, so we're not particularly enamored with the idea of putting specific contract term language in, but we were enamored with the idea of drafting some policies that would actually clarify a process to review the particular situation and to develop a plan that would allow us to go forward.
A quick question on that, if I could.
Yes.
In addressing that policy, do you see the potential for there being hospital-unique plans for how to share those savings if they're looking to exceed 10%, where it could be different from hospital to hospital, or would you be looking for a consistent approach across all hospitals that exceeded that 10% and looking for some approach for how they might share the savings? Have you thought through that yet?
I think there should be some consistency, but I don't think it will be, I personally don't think it would be completely consistent because I think we have different situations around the state. We have sole community providers, and we have we have areas where there is excess capacity that might be eliminated. Where so I think there's different situations around the state that will need to be addressed, and different investment approaches. There are different situations in terms of how large avoidable volumes and fixed costs are. So a hospital that has a new facility might have higher fixed costs than one that has an old facility, for example. So I think that we need to be diligent and even-handed, but recognize that not every situation is exactly the same. Are there other?
On this whole topic, which is, I think, very, very important, is there going to be a work group to discuss this in more detail to try to help provide some more guidance in this area? Because I know you know it's not black and white, and it is you know, a concern of hospitals about how much they can save in their operating costs until there is substantial reductions in utilization, because there can be so much fixed costs, and smaller hospitals will be challenged to save a lot until they get a lot of utilization out, because there may be only a few nursing units, and you have to save real money by closing a nursing unit. And you may find yourself having to get rid of, if you have 3 nursing units, a whole nursing unit, a third of your volume before you can save any real cost. So I'm not trying to solve the problem now. I know you know it's complicated, and I think it's really going to be helpful if hospitals have some guidance here. So that's a long way of saying,
Would you
if there's a group,
subgroup?
I would love to have a subgroup on this, and I will come.
Okay. Well, that's a later topic, so we'll put that onto the later topic list. We spent, I would say that we spent 3/4 of our contract meeting discussions on that topic. So I think we can say that there's interest in continuing interest in.
Look at it this way: there's lots of optimism that some good things can happen.
Yes. So there are other policy issues there too. For example, of hospitals that are having volume drops, of providing new services with some of that capacity. So I think there's there's some ups and downs in that equation.
Donna, what's the base theory going to be for the launching point for the volumes? Is it the calendar year 13? I know it's a detailed question, but
Hey
Donna, this is Gary Simmons. Can you hear me?
Yes.
On that subject about having, this on this section, having a separate work group that might include members of the physician work group, because however we kind of address this, to make sure appropriate actions, I think, that a lot of the utilization is going to be driven by physician action. So it would, I think there should be some alignment between what's going on here and the physician work group that ought to work simultaneously together.
Well, we'll be happy to have physicians on the work group if folks are interested in the policy discussion. We're not actually focusing on the operationalization of it, but I do actually think there is interest from the physician work group in the topic, particularly as we get into areas where if the hospitals should develop alignment plans with the physicians that have funding of shared savings or gain sharing with the physicians, then there's some interest in making sure that the funds will be maintained in the rates of the hospitals and not reduced out of the rates from the savings that are made. So I think there's definitely a policy interest, and we're glad to have physicians physician representation. And we've had in the contract subgroup, we had a representation of you know, the various parties at the table here. The last policy issue related to this. Oh, sorry, the timing. What it actually kind of works its way into the next point here, and we're focused on using fiscal year 13, but then rolling that forward for the volume adjustments that were made in calculating the 2014 global budget. So that's the plan of attack, is to volume adjust the base period based on that on the volume adjustments that were made. So there were some volume adjustments that were made up through December 31, and then there was a population adjustment that was generally made for January through June that gives a volume factor that can be applied to the base volumes. Then moving forward, it generally, in terms of putting corridors in place, we need to fix the volumes, if you will, because otherwise the corridors, if we rolled forward volumes every year like we have historically, then we would release the corridors every year, and so they wouldn't really be effective as a policy mechanism. So that gives some folks a heartburn, because it could make the rate realignment a little messier. So we do have an approach to enable us to roll forward the volumes but still maintain the corridors based on the initial global budget. And just as an illustration of that, which of course we would develop in more details for everybody in the policy paper, if a hospital's volumes dropped by 3% after the initial volume setting, then when we rolled forward their volumes for the next year and produced a rate order, and we multiplied the rates times the approved units in the rate order, then those rates times the approved units would arrive at revenue that's 3% underneath the rate order approved revenue, so that we can effectively carry forward those corridors, yet still do effective rate realignment. So I know that's all a little complicated, but those are the trade-offs. If you want to do rate realignment, then we have to make the units priced out to something that's other than the global revenue, knowing that the compliance target is still the global revenue on the rate order. So that's all complicated, but mechanically accomplishes the goal. Then the last area is the December 31 targets. While we've got fiscal years, we need to hit December 31 targets, and we will be issuing targets and focusing on having a contract addenda for both TPR and non-TPR hospitals with the December 31 target agreed to by the hospitals. So basically, we would the actions that we would be focusing on for immediate attention, unless someone has other actions that require, or items that require immediate attention, is to work on the reporting templates with subgroups, develop a contract addenda with overage and underage policy changes, and a contract addendum with December 31 targets, and continue to work on the policies for underages and or unit rate corridors with a subgroup that Hank will be on. So those are the planned actions coming out of the review process. Does anybody have a difference of thought or any way that you wanted to process this, Mike?
Just one, actually, maybe an addition or clarification from my recollection of the contract subgroups discussions. And this goes back to the demographic adjustment that we just talked about. In the TPR agreements, there was a slightly different population adjustment that was used in that renewed agreement. I don't recall whether we concluded that in this updated template whether we would adopt or if we will replace those population adjustments for the TPR with this new methodology, or they would stick with the numbers that's in their 3-year agreement. So that was one additional one that I thought we might need to add if we were intending to replace in the TPR agreements with the new demographic methodology.
Yeah, I don't actually know the answer to that question, and their inflation adjustment language reads differently too. So we'll make sure that we address that in the short term. So right now, I think the way their inflation policy reads, they might be entitled to the 1.7 instead of the 2.4. Okay. So
we'll need to look at those, please.
But no, that's we'll take care of those we'll let folks know what happens out of that process.
Thank you.
Any other questions or comments? And we can take written comments after today's meeting as well, and from any of the organizations. We were going to change the order a little bit to allow some folks I think Mike has to leave to go to another meeting, and Jack is meeting with our French delegation who are here visiting with us a little bit later. So I want to make sure Jack said he wanted to talk close to the 3 o'clock time.
Donna, I'm here.
Okay. Okay. So we were just I was just checking my watch versus the clock here. So we're going to skip down to the discussion of principles for market share. And just as a preface, the staff is gearing up to start working on calculations for market share adjustment, and we wanted to start that process by having a discussion of the principles that will help guide us as we begin to do our footwork in terms of calculations. And we've have had several white papers. It's been a while. We have still have one that's probably going to be sent out later this week. We have a new white paper from the Healthcare for All, and there is a document called Draft Discussion Points that you should have, where I went through the white papers that we have and pulled out some of the points from the different white papers. Jack Cook was going to briefly present some of the key points in terms of principles and definitions from the Care First white paper, and then we wanted to get into a discussion of some of the principles and see if we've captured them and where there's some initial consensus or where there's some disagreement. So, Jack, do you want to take us through your PowerPoint?
Sure. And thank you very much for organizing it so that I can meet with the French delegation. I think it's ironic that the French should be here asking us about our healthcare system. But anyway, since they seem to be ranked #1 in the world by almost everybody. So I'm assuming that the PowerPoint's available to the folks who are at this meeting?
Yes.
Okay. Well, if we go to page 1, the topics that I wanted to cover, and they'll be fairly brief, are the demonstration requirements as Care First sees them relating to market share adjustments, and then some suggested principles and examples of how market share adjustments might be carried out and limited. So on the first page then, I just recorded what I thought were the key features of the demonstration, and they include, as noted, that a certain proportion of Maryland hospital revenue must be covered by population-based payment in each year. If the GBR were acceptable to CMS, we would have succeeded handsomely in meeting that particular condition. One form of population-based payment, there are 2 forms of population-based payment specified in the demonstration, but for our purposes, the form that's most important is the form that requires the establishment of a fixed global budget for hospitals for services unconnected to a specific population. And I've underscored the word fixed because the descriptions of population-based payment in the demonstration are fairly imprecise, and I think it's important to focus on the character of the population-based payment as being a fixed global budget, as being distinct from and separate from a system in which there are volume adjustments. In particular, the demonstration contemplates that there would be the possibility of a continuation of the CPC system for certain hospitals. And the difference between the 2 systems, as I see it, that is to say the GBR system and the CPC system, is that the CPC system guarantees volume adjustments for volume increases for the hospitals. So in particular, point 3 is that a global budget such as the GBR arrangement is in my view, not fixed if it is subject to volume adjustments. And therefore, a market share adjustment in the GBR must be fundamentally different from a volume adjustment. And that means, it seems to me, that our challenge is to define the market share adjustment so that it is not a volume adjustment, so that it is clearly separate and apart from volume adjustments and serves the purposes of population-based payment. Now, I think it's fair to say that there should be 2 forms of market share adjustments, one of which would be formulaic and one of which would be process-driven. And for the rest of this discussion, I would like to focus on the formulaic part. In that regard, it seems to me that a population-based payment system requires, first of all, the specification of the population to which the market share adjustment would apply. And then it requires a specification of the services to which the market share adjustment would apply. And then in the best cases, and I'm not sure this standard can always be met, but it seems to me that it's in the character of population-based payment that the redistribution of covered services, which we would call the market share change, should result either in lower cost or demonstrably higher quality. That is to say, it should be distinguished from just the ups and downs of volume fluctuations that occur randomly or occur as a result of inducements to hospitals' medical staff to do more services, or perhaps in some cases to do less. And finally, to the maximum extent practicable, we at CareFirst think that each of these adjustments should be at least budget neutral. In other words, it would not be advisable to have a whole series of market share adjustments calculated over the whole industry and at the end of the day try to have a budget neutral adjustment that applies in the aggregate to all of those market share adjustments at the same time. Now, in our efforts to distinguish the market share adjustment from a volume adjustment, it's very important to keep in mind what we are trying to do with regard to GBR hospitals. The first incentive is to eliminate marginal or unnecessary services. And we don't want volume market share adjustments to disturb that fundamental incentive. So in particular, we don't want the fixed global budget to vary based on random fluctuations in the volume of the services of the GBR hospital. Nor do we want the fixed global budget to vary as a result of variations in the volume of services of other hospitals. It's very easy to have a change in a hospital's market share, assuming you can define the market precisely, that results from actions of other hospitals, even if the GBR hospital that's subject to the adjustment is operating with the incentives of a fixed global budget and is doing its best to remove marginal or unnecessary services. And then finally, we want to have the target budgets adjusted only for the redistribution of covered services of a specified population. And we want the overall effect in the best circumstances to result in a decrease in the volume of total services that are subject to the redistribution, which we're calling the market share adjustment. Now, I want to just go through, a couple of examples of what seem to me to be circumstances where a market share adjustment is called for, and then to discuss some circumstances where it's not. So in these examples, I've suggested that we have two hospitals, a community hospital and
some categories of principles and definitions from the white paper. So there were a number of principles that were laid out in the white papers around providing clear incentives. Emphasizing value rather than volume, rewarding improved utilization, not reducing budgets when hospitals have to invest in interventions, not diminishing resources available for care coordination, encouraging reductions in utilization that help achieve the three-part aim, and the next should actually have a bullet, discourage reductions in utilization that undermine the achievement of the three-part aim, and avoid incentives for overutilization that undermine the three-part aim. So going through the papers, those were the comments in the various papers that were raised about incentives. Are there any questions or comments here about that category? And I should say that we'll give everybody a chance several times to look at the papers that have been drafted and to think about this and provide written comments. But just if there are any initial reactions to some of the commentary about incentives.
Hey, Donna, it's Hank. I think what Jack said towards the end, and by the way, the points are, so it's very noteworthy, but at the very end, the comment was made, it's just very complicated. And I will tell you, I agree with that comment. It's really not black and white at all. And a couple of thoughts, and I don't have a solution. I think we have to make sure as we develop policies, we take into account various angles. And one of them is the patient. Nowhere in this conversation do we mention the patient. And I think we have to make sure that we never take away a patient's choice. And I think we do want that patient to make its own his or her own choice. I think you want physicians who are providing care to their patients to be able to give choice. So so I'm a little worried that we may lock down and say you have what you have. Let's not worry about innovation. Let's not worry about competition, because I'm not able to try to pull your patients to my hospital under the belief that I believe I have a better service to provide. And I just think we have to keep competition alive in these models and keep the patient's choice in mind. And to give you another example of how you can't anticipate everything that's occurring, but I know of a situation where a hospital has been on red alert in the emergency room, which means there's bypass, which means the ambulance is not stopping. They're moving to the next hospital, and it's happening at a record level right now. Those patients don't have a choice. Those costs are being incurred by another hospital. And so there are going to be plenty of examples of this where there's mass movement going on, or the hospitals or the patients don't perceive choice, and physicians don't perceive choice. So I think it's complicated. I just wanted to make that, I want to reinforce that point. And the more one thinks about this, the more you can drive yourself crazy trying to find that right balance. I would say this for sure, if there is increased utilization anywhere, that's just creating volume. Unless that's driven by aging or population, those use rates should not be reimbursed for sure. And I do believe that the revenue should follow the patient. So just thoughts, more to come, I'm sure.
So I think on the question of patients, I actually think number 2 here is all about patients, about reinforce the maintenance of services to the community. So that was the second set of. Number 2. We had provide clear incentives as the. Sorry. Oh, there's no number. So there's no number. So the second category. The second category is reinforce the maintenance of services to the community, and also actually, if you looked at the details of the white paper, you would find that discourage reduction in utilization that undermines the achievement of the 3-part aim is also all about patients. So I think there's an awful lot in here that's really, we're looking at this document. You're talking about, oh, okay. So yeah, so we're moving into the additional areas because other folks have spent considerable time writing white papers, and so I took care first comments and I included them here, but I also included everybody else's points. Not surprisingly, Healthcare for All did a very good job of focusing on the patient's interest, and we've tried to capture those in this document, and we're very focused on that as part of this discussion. One of the major reasons for doing a market share adjustment is to make sure that we don't lose sight of the patient and the needs of the patient and the needs of the community, so of considering it. So I think, so we have the the focus on incentives, and the second area really is focusing on making sure that the market share policy reinforces the maintenance of services to the community, and so you'll see some of what you just said right now, and I did in addition to monitoring transfers, I did add monitoring changes in bypass of ambulance also as something that we might want to monitor. But these are things that we'll have to see.
Is one of the premises of the market share increase going to be that there needs to be savings to the community?
I guess that remains to be seen. I think what we've captured in here is that that there shouldn't be dis-savings. I think that, or that there. I think that the adjustment should result in, unless it's a quality-based change, that it should not result in dis-saving. So if we move from A to B, it shouldn't cost the system more money.
Can I ask, and this is a basic question, if this is not the appropriate time, tell me. Oh, I need this. Excuse me. Thank you, Paul. Sorry. Hi, sorry. To be very simple, trying to understand this, but saying the distinction between volume and market share. If you were to just say that, or even in a document, try and have column 1 and column 2, volume adjustment is this, market share adjustment is that. Or if you were in a as simple, straightforward way to say, these are the distinctions, even right now, that would be helpful.
Okay.
And maybe not to others. If others know that, okay, but that's just something still. I mean, as I was listening to, again, the follow the money theme, we follow the patient. The money follows the patient.
Right.
We all, in a time like now with so much change going, I think we all have to, we know that is the most important. But then when we talk about that, if the teaching hospitals services increase, and it is not because of a change of level in service in the community hospital, then we're not going to pay for it. I mean, I know these are very complicated things, but again,
that doesn't say we're not going to pay for it. It says we're not going to treat it as a market share adjustment.
Oh, okay.
So we might pay for it because we might have some other policy, for example, with the categorical cases, with the transplant cases. We said that if transplant cases go up, that we're going to pay for them. But that's not a market share adjustment. It's just a volume growth. But we made an exception for that very small sliver of cases. So that's a volume growth. It's not a market share adjustment. On the other hand, what Jack was saying. So we can actually create maybe some tables that would help other folks understand. So that's a very good suggestion. When we were looking at negotiating the GBR agreements, we would hear, well, we've had a market share increase. Well, sometimes it was just a volume increase. So let's say your volume goes up at a hospital by 10%, but the population only went up 1%. If some other hospital didn't have a volume decrease of 10%, then there is no market share shift. It's actually a volume growth. So the hard issue that we have to struggle with is to determine whether something is occurring because the volume grew or because services shifted. The other problem also occurs. So, for example, and this is real life data as well. So we have some hospitals that are doing exceptional job of attacking readmissions and doing a good job with working with the nursing homes to reduce infections and UTIs and things going on in nursing homes. So there's lower admissions coming into those hospitals. So they have a volume drop. So I don't want to reward some other hospital with a market share increase because I'm looking at some percentage showing that Hospital B's volume went down, Hospital A volume stayed the same, so therefore there must have been a shift, because there really hasn't been a shift. It's just that volumes drop. So you hit the nail on the head. We have to try to do the best job that we can to separate volume changes from market share changes. And then where you're going to, in addition to the difference between those two, you're going to find some disagreement as we work through policies about which market share changes should be recognized, how much money should be shifted for market share changes, and a variety of other topics. So I think that's very good that we should, you're saying, Donna, do a better job of framing this so folks can grasp what you're talking about.
For me, this is tremendously helpful. And I don't know how it is for others, and I don't want to take too much time, but it's like a conversation I had this morning, and it's about the state budget, because I was reading an article about cash flow, cash deficiency versus a structural deficiency in the budget. So I called the head of budget analysis for the legislature, and I said, tell me what the difference is. Well, the structural deficit is what's ongoing. The cash deficit takes into account any surplus from the prior year, any one-time loans, any one-time dedicated funds, transfers from the Transportation Trust Fund. I mean, so you're telling me, so it's very helpful. I think it's, to me, very important. So thank you.
Okay.
Yeah, this is Theodore from Healthcare for All. Just wanted to, first of all, express my appreciation for the work that you and your staff did, Donna, to try to pull together disparate white papers and identify the key principles. I think you all did a really wonderful job. In terms of our white paper, the key point we wanted to make really is that market share adjustments are an important consumer protection. That is, if there's a hospital that provides terrible care or bad consumer service and drives customers away to another hospital, that first hospital needs to experience commercial consequences. And the market share adjustment is a way for that to happen, so that a hospital knows if it provides bad care, it will see its global budget in future years reduced as a result. And I think that's actually, it was striking to me hearing Jack's presentation how many of his conclusions we reached coming from a very different point of view. That is, we also agreed that for a market share adjustment to be paid, it has to be the case that volume shifts from one hospital to the next. It can't be the case that there's an overall increase in systemic volume that may be warranted for payment, but it's not a market share adjustment. When we calculate what goes into a market share adjustment, we should be subtracting out things like hospital-acquired conditions, rehospitalization, other preventable, potentially avoidable utilization that's within the control of a hospital, precisely because you don't want to disincentivize hospitals from reducing those kinds of things. So we need to really think about, what sorts of things we want to encourage hospitals to do, what sorts of things we want to discourage hospitals from doing. But I do think one, from a consumer protection standpoint, one really key function of the market share adjustment is to use market forces to encourage hospitals to provide good care.
Yeah, Don, I'd like to comment on that. I think that's a very insightful view, and one way in which that can be done, which is elaborated in much more detail in the Care First paper, is to recognize that entities that are under risk-sharing arrangements, like ACOs or like the medical panels in the primary care medical home program of Care First, may very well make choices which they see as increasing value, increasing quality, in situations where a hospital is not clearly operating in a market. That is to say, it doesn't have a patient service area that is comprised of residents that it serves primarily or exclusively. So, for example, you might have a hospital like Mercy, which has a lot of high-quality services. In the event that there is an increased flow of patients to Mercy because these risk-sharing organizations see Mercy as a desirable place to have the patient's care rendered, then in that circumstance, it seems to me that we're sort of considering the converse of the suggestion that's made. There, the argument is that care is better. We can presume it's better because these entities are looking to maximize value, and therefore a market share adjustment to Mercy would be appropriate, even though Mercy doesn't have a well-defined population that it provides its services for.
Donna, one thing that I saw that concerns me is that it's the consumer, but it's also the physicians. If the physicians want to practice at a particular organization, that shouldn't be precluded by a policy potentially that doesn't allow the revenue to follow the patient. Now, that being said, and one of the reasons I asked would there be savings or no dis-savings is to the extent that the consumer pays no more money for that, they're not subsidizing for a transaction. So the reimbursement methodologies shouldn't have amounts built into it that pay for subsidies to physicians being acquired by hospital systems. But we shouldn't have a policy that precludes a physician from moving from organization A to organization B, saying that the revenue won't follow, because that physician component of this is very important as well.
So you're saying while we shouldn't build that into the cost structure, if the patients move, and the money should move.
Yeah.
And it's not a volume increase, so it's not a volume increase, it's not a volume decrease, but if they move, as long as it's cost neutral and quality positive or quality neutral, that the money should move.
I can just lay out one question for, I think, maybe more discussion at a later time, but I think we're going to need to spend more time on this issue of savings or dis-savings to the system from these market share adjustments. And I'll give one simple example using the approach that Jack just outlined. If there is a market share adjustment, a clear market share movement from hospital C to hospital T, we know at the very least that hospital T has certain social costs, teaching costs, that may not be inherent in the cost at hospital C. So if you simply move that care, and let's assume it's a care being moved because the care at hospital T is better care, you move that cost, but hospital T clearly costs more simply because it has a teaching hospital component. It would seem to me in that case there would be cost dis-savings even if there was an improvement in quality. So I don't want to belabor the conversation now, but I could see, just using that as a simple example, where there would be market share adjustments where there would be dis-savings. And I think we just need to come back and maybe have some further discussion on that issue.
and I think that there will be I'm sure many conversations. I guess the staff is getting ready to begin calculations and modeling and starting to dive into some of the modeling detail. Is there any advice that folks would have as we dive into the process? In addition to the advice that has come out of the white papers and that we've started to talk about here. And again, we'll be glad to take the advice in emails as well.
This is Stu. I have a couple of thoughts about that. This is a very interesting discussion, and I think it's important to get the kind of philosophy of this clarified. But of course, there's much more than getting the philosophy straight. But I'm trying to think of it as I kind of see two levels. There's a community level impact of shifts in volume, and then there, or in market shifts in market share, and then where patients go, and then there's the effect on individual facilities. And I think both need to be taken into account because you've got a global budget. And I guess and even if we get total agreement on how we think about these things and come up with Barbara's get Barbara's table so that we all would vote to approve it. The complication is that a lot of these things are happening at once, and the problem that HSCRC is going to have is figuring out how to sort out, what is attributable to which of these factors. And I think that's, but I think some of that can be ameliorated by understanding that we have a global budget system that we're trying to move toward, and we have to, consider first the impact of the budget, and then the second question is how that budget gets distributed across hospitals, and that may help kind of clarify the thinking of how we, you could say the money should follow the patient, and that's great, except how much money should follow which patients for what reasons, and that's what we're grappling with here.
And I don't want to belabor this because it was raised, but like on the physician issue, just an example. For those who have been here in Maryland, DeMonte Driver, young man in Prince George's County, died because he had a dental emergency and no dentist would take Medicaid, and so the state undertook a dental action initiative, and they went, that program had been funded like $52 million. Now it's $170 million. I represent anesthesiologists, emergency physicians, other physicians. The anesthesiologist saw at one hospital an 800% increase in the number of those pediatric dentist restorative cases. And it was such that they were trying to get the prime time in the OR anyway. Patients were coming from all around the state because they had the equipment and they had the expertise. Now, if that oral surgeon decided to take those cases somewhere else, again, what happens in a shift like that? What happens is, I think you were alluding to, if a cardiac group or a surgical group, wants to move to another hospital. I mean, those are just things we have to be, we have to take into consideration. So, like, it's been said already, but I just felt like, it really rings true that there has to be that fluidity that is accommodated in whatever is developed.
I think there are other solutions, but they're more extreme. And one, that there is a thought process that would say, and well, we shouldn't be staying in a global budget model very long. We should go to a population-based model where we assign one patient to one hospital, and they're responsible for all of the services of the patient except for whatever we carve out. And so that is that is a whole different level of complication in terms of tracking. It's a whole different level of risk for the boards of the hospitals and for the hospitals, and so it's my sense that we're not ready to go that route, and that we're still going to focus on trying to do things like market share adjustments and not move to a pure attributed model. So I just want to check to see if everybody agrees with that, or there's anybody who says, hey, let's go for the attributed model right away. Our boards are ready to take that on. Not seeing a lot of takers on that front. So, because that could avoid some of the complications of the conversation about policy, but it would introduce other complications.
I'd like to make a couple of comments. First off, although I agree with Hank that it's complicated, I think it's kind of a rabbit hole to make it overly complicated. I think over time there is going to be a natural shift in the distribution of the services, and the more you start factoring in all this stuff, it can get perhaps needlessly complicated. So my advice to staff is to try to simplify it as much as possible. I think both Jack and Stan have outlined some good framing principles, and I think don't try to overcomplicate it. But I don't know if you were going to go down through this whole list here, but I do want to add one point to item 2, which I think is missing.
Okay.
That in addition to competition, that there should be collaboration among hospitals to reduce the possible redundancy of really expensive services.
Okay.
That's it.
And I don't think I'm really not going to go through this whole list right now, because I want to give folks time to look over it and think about it, and ask you to provide written comments. So I know that you all haven't had a great deal of time to think about this, but are there any categories of principles that are just missing? And like I said, I think that we'll let you sleep on it and send us written comments. And I'm positive that we're going to have more conversations about it.
I just want to make one point on the PAU side. There are two votes here which seem contradictory. They exclude PAUs, exclude if they are not related to PQIs. I think we are, in our current thinking, PAUs are going to be a different category that we're going to monitor, because if you think about it, there might be some market shifts there that you may want to do adjustments. If certain physicians are shifted, then maybe certain PQIs are going to shift to another hospital. If you are looking at 2 hospitals, you're going to see a decrease in PQIs, for example, in one, and increase in the other, which will have nothing to do with the hospital performance. So I just, in terms of calculations for the market share, we just need to separate services that may have different dynamics, and when you see a number, you see a different thing rather than the market share. So I'm saying that you would have a market share adjustment just looking at the PAU separately from the rest of the services, because we are expecting decline on those services. You may not expect so much decline in some other ones. So, like, trying not to complicate things, maybe we can think about differentiating services based on expected trends. For example, for the prenatal services, it's not going to be hospital supply-driven volume increases there, so we don't worry about the volume there, versus PQIs, we worry about the declines.
Or as an example, let's say that Charles River places 5 primary care physicians in the community, and And so more of the primary care services are maintained in the community instead of going to the primary care physicians in Community B. They're going to having their primary care in Community A. So the patients there might not be any change in avoidable utilization, but the patients might go to Hospital A. So Shuley's just recognizing that we might actually want to account for a shift in patients as opposed to, again, this gets back to Barbara's comment of try to help us understand volume shifts versus market share shifts. So this would actually not be, this would be a real volume shift in that particular instance. So we're not discounting that that could happen. So that was the point. Other comments? Well, I think we want to get into the data and try to really get get as clear a picture as we can from the data to help us through the process.
Muted.
Then we have a few more topics to get through for the day. We can go back into the agenda, and we wanted to talk about prioritization of some of the work that that we're going to be doing, and we'll again, but in the upcoming meetings, but at least to have some initial discussion of things that we're working on and timing. Summer is here. People have to go on vacations, and we've just taken our foot off of the accelerator to get policies completed that for the update policy, and now we actually are going to have to take some time to do data analysis to support some of the activities here. So we don't want to have meetings to discuss things purely in the theoretical sense. We want to get the data into the process as quickly as we can. So the things that we're thinking about that have come out of prior meetings are transfers and getting the mechanics and data in place to evaluate payments or changes in payments for transfers to changes in transfer levels from hospitals to Johns Hopkins and University Hospital, should they occur under global budgets. The second issue is market share, which we've started talking about. And these two issues are, at least as far as the HSCRC staff, are high in terms of our priority and data development priority. The third area is guardrails, and there are multiple sets of guardrails, and I think we're going to discuss some of them at an upcoming meeting. Plus, we have a principles discussion after this section. But at a minimum, we want to go down the road of developing some guardrails that could be, or some policies that could implement revenue adjustments should we need to if we're not meeting the requirements of the model. So how would we adjust revenues? Then there are a series of other policy issues that are here for consideration. Starting with capital policies, which obviously also involve MHCC, gain sharing and shared savings, which involve the physician work group, the evolution of the model, which we said that we would put off until after we got some of these other things done. And then folks are also talking about post-acute care and bundled payments and some other topics. And so in terms of things that we need to, I'll say, put our foot on the gas pedal on, the staff has prioritized the first 3 items on that list as our top data analysis priority, if you will. And I guess we'd like to hear if there's other input on priorities. I think capital policies is something that is a burning issue for everybody as well, and we are to have Paul is going to give us a presentation at our next work group meeting. But are there other, is that the right priority? Are there other things that we should have our foot on the gas pedal looking at right this second in this work group? Mm-hmm. And they're also somewhat being worked on in other work groups as well. So I think so you're saying moving quickly up to the top are gain sharing and post-acute. So you would move them up in the list if we're trying to get a priority list here.
Evolution of the model is the big umbrella, and it, from my point of view, learning so much, just sitting here on the hospital side, being much more familiar, again, on the physician side with the challenges and so on. But the evolution of the model, I mean, I think that, maybe it's just my reading, but that's kind of an umbrella for all of this. So I don't know how or where you put it in the category. Maybe I'm seeing it differently, but I would think maybe every 3 meetings or every other meeting, or maybe we have just leave a little time for this group to comment on, I'm not sure, or synthesize what we know so far collectively. When I say what we know so far, maybe even, maybe this is premature, but taking into account as much as can be incorporated even from the other work groups in terms of evolution of the model. So I just put that out there as, how to prioritize it or how to incorporate that into future agendas. It's because I think that is the invitation to all of us to think broadly.
I think that's good advice. And I think some of the discussion about that is taking place in the physician work group at this point too. So because part of where the model is headed is looking down the road and how do we engage others outside of the walls of the hospital provider. So I think that is something that probably needs even a broader focus than just the payment work group, that we really do need to kind of reconnect with some of the other work groups as we enter that conversation.
I'm not sure where this fits in here, but it seems to me that if we want population health improvement and we want hospitals out in doing things in the community, that in situations where multiple hospitals are serving that one community, that there's going to need to be some collaboration and cooperation between the hospitals, which is a different model than the competition model that we're working on right now. Because if one hospital invests in the population health, their competitors in a competitive model benefit too. And so why would you do that? Some people might call it a free rider problem. And so I don't know where that fits into this, but market share is part of that. Market share adjustment is part of that, but just kind of how do you provide the incentives to work collaboratively in the community in a totally different way than you're used to competing against each other right now for patients. I'm not sure where that fits in, but I think it needs to be in the discussion somewhere.
And I think it also ties into the issue that was raised in the advisory council, and that is certainly being talked about, but not here at this point in time, is how do you fund care management and how do you organize care management. So it fits into the same sort of conversation. So basically, your advice is we need to talk about some of these big picture issues, and we need to think about an effective way to do that. And we might need a few other folks at the table to do it who are working in some of the other work groups.
And I think there's a payment aspect to this, which brings it to this committee. Mm-hmm. Because there's going to need to be some real dollar investment, and the ROI is return on investment is going to not just the person who's the hospital. If one hospital makes it, it's not just going to go to that hospital. Admissions or budget. So how do you deal with that from a payment standpoint? Mm-hmm. And how can in the with the antitrust laws as they are, create an environment where you can collaborate without problems, legal problems too.
It's not a perfect world with antitrust, but the regulation actually alleviates some of those issues. It doesn't get rid of all of them, but it does alleviate some.
Not for the physicians.
No. Well, no, they're not. They're not rate regulated. So.
No, but I mean, even as we talk about sharing information and doing things differently, that's something.
When one talks about sharing payment information, then that's yes. when it gets a little dicey. Mm-hmm. But in the hospital side, it's regulated and it's public information, so it's not. We don't have quite the same issues as the physicians and payers do in terms of cross-sharing information. So we'll what we'll do is kind of take this advice and go back and think about it with Alice. Alice Burton helps us plan all of our meetings and our thinking process, and so put it into our thinking cap of how to organize it and orchestrate this thinking, and how to do that over summer vacation and meeting some of the other areas. With that, we'll move on to the discussion of guardrails, and I always like to have the Hospital Association representative here when we start talking about guardrails, since it affects all of the hospital payments when we start implementing guardrails. So he left. Let's see where we can go with a brief conversation on that. But I don't want to go too far into the conversation without having Mike at the table, since he's done a lot of work in collecting information from a lot of hospitals to discuss the topic in general. But we don't have, unlike the market share where we have a large series of white papers on the issue of guardrails, not so much has been done in terms of writing. I think the staff had started some initial thinking about the guardrails, and we presented at a prior meeting to if we should not be meeting our Medicare savings targets or not meeting our overall targets. One of the areas that we were thinking about in terms of providing some payment adjustments would be in the area of avoidable utilization, so that if we were looking at places to go out to explore, that is one of the things that we had in mind. I guess when we look back to many, many years ago, before some of you were born, we also had Medicare screens. We had a number of different tools, and I guess in addition to the topic of avoidable utilization and bringing that back as a possible approach to implementing reductions if need be, are there other principles or things that we should be thinking about and looking at as we tee up some work on this for the work group? David, where would you like to think that we should be focused on if we're focusing on developmental efforts around the possibility of needed reduction?
On the I'll start with the first item, and then I'll give you another idea. But on the potentially avoidable volumes, I don't think we should lean into the PQIs because hospitals haven't had time to do anything about that. Readmissions and MHACs or that, I think, is potentially an area. But maybe another area is a volume. If a hospital has accomplished a 10% volume decrease, maybe you look there a little bit. If there's been savings, maybe there's a pocket there if we get into a guardrail situation.
Do others have thoughts about avenues we should explore? And I think principles is another issue, and we can come back with some principles as well, but avenues that we should explore.
Can you help me to understand just what you're trying to accomplish with guardrails?
Okay. So there's several guardrails in the waiver test. I mean, for example, we have to have an increase in total cost of care that's less than 3.58% per capita, and we're required to produce Medicare savings above a certain level. And also there are some guardrails in the application that look beyond the walls of the hospital to say, well, even if you do both of those, but your cost of care that includes physicians and nursing homes and everything else goes up faster than the national average for Medicare, not for all payer, but for Medicare, then Medicare will we have to make an examination and implement corrective action. So I think at one level, our initial focus is really on the 3.58% test and the Medicare savings requirements to say, if we're not meeting them and we decide, if we decide that the best course is to reduce revenues, how should we go about deciding whose revenues to reduce? We could reduce revenues across the board equally to all hospitals to say, oh, we need 0.5% out. Let's take 0.5% out of every hospital. We could try to target the revenue reductions based on existing cost of care, where we think where is the cost high, where is the utilization high. So I guess, stepping back up to the principles, the issue is where should we focus in terms of, and what kind of principles should we put into play in the event that we have to move quickly because there's a target that we're missing. And if it's an across-the-board percentage cut, we can move quickly without having any conversation in this room. And so if everybody says, well, Donna, this is great, let's just drop this conversation and we want to do across-the-board percentage cut, we don't have to spend any more time on it. That's one thing. So the second thing is, should we be focused on looking at where costs are higher in the system if we have to make cuts, or should we be looking to do across the board?
So to put it in terms that I can understand, you have some basic, you call them guardrails, with the basic targets that you need to hit with the waiver program, and you're looking for sort of backup targets that if you're missing the prime target, by focusing on those backup targets, you can achieve your main target.
Right, and should we do that across the board, or should we do it with by looking at cost or utilization variation? So, there's only two things that drive results: cost and
I'll
use.
give you one cautionary. In the old models, other state models, private payers pay a disproportionate share of costs, and I don't want to see representing those private payers would not want to see, if we're not hitting the Medicare target, that take it out on us. For what it's worth, department.
So Donna, wouldn't the 3 point, I'm thinking about the test that will get the greatest attention, the 3.58, I doubt, knowing you, that you've set a situation up under global budgets that would put that at risk too much. So let's put that one aside. That's just a guess. The other one would be the waiver test itself. I mean, the Medicare test itself. And there, I would say, look to the providers that have not participated in a solution, and not to discourage those who have done well, reduce utilization, and look to them to say, well, geez, they've actually done well. Maybe I can take some of their resources and move them to benefit the new waiver test. I would do quite the opposite. That may mean you're coming after our organization. I don't know. I would hope not. But nevertheless, I think you kind of hunt where the ducks are, and the ducks would be in the organizations who have not yet played. It seems like the fair thing to do. I would say to the group here, speaking for our health system, Donna mentioned something that I don't know how well it's appreciated under new waiver. But while this is a hospital rate regulated waiver test, there's a very subtle piece in this waiver that basically could cause the waiver to fail, not because of what any hospital did, but if in fact everybody else is still pumping up volumes and the revenue per capita for Medicare grows at a higher rate than the national level, not because the hospital piece wasn't being managed by the HSCRC and the hospitals, but the other party. And we'd have to spend some time to make sure that we are not held accountable for that, which does give you some pause here, because while that revenue may be growing in the other 60% of healthcare, if the only nail they see to hammer is the hospital, there's a problem. So anyway, I wanted to make that. That point does give people sleepless nights.
That point, are you getting at the Medicaid expansion here and what we're seeing, or just what I'm reading, and in terms of anticipating what that could mean about a sicker population that hasn't received health care for some time, that Medicaid. Did I say Medicaid? I said Medicare?
I'm speaking about Medicare.
Oh, you're talking about Medicare only. Okay. Okay. All right. Well, I said I'm thinking about the Medicaid population and what that is going to do to hospital volume. I mean, I don't know, but I just, again, how is that going to be factored into the market adjustments or the volumes and how sick those patients are? This is questions I have no idea what the answers to, but it's just something that comes to mind with the tremendous influx we're going to have with newly eligible Medicaid.
Donna, it seems to me you guys, HSCRC has been pretty sophisticated in its analysis of the pieces of this. And so if you set up a dashboard, with where red lights go off in the components of the system where costs are being exceeded, then you can focus on those areas, and that'll tell you two things. One is it tells you where to look for the potential problems, and then you can figure out if it's potentially avoidable utilization, then you can look at that. If it's other areas, you can focus on those. But it also tells you where the red lights aren't going off, to look there for examples of how those components of the system have achieved what they need to achieve, and figure out how to spread those, or at least refer the problem areas to the areas that aren't having problems, and say, look at what they're doing. It's doable because that a lot of the state is going to make their targets. So that'll give you a better idea about how to target stuff that you need to focus on.
Just clarification, so you're thinking about also doing with other states or the national benchmarking?
No, within the state.
Within the state, okay. Good. I thought about...
So the dashboards are, if, for example, if utilization is rising, if utilization isn't falling, or the things that are critical success factors that we're trying to measure that we think will be indicators of success.
Right, and you can start with the broad ones.
Hospital.
So you can do it by hospital and by area, and then kind of dig down. If you see a light go on for an area, you look at the hospitals, and then you can see whether it's the problem's traceable to one hospital or a set of hospitals in an area, or if it's across the board in that area, that it may be an area-wide problem.
And that there could possibly be problems that are generated outside of the hospital. So, for example, one of the problems as we look back to last year is that bad debts rose in the state, and that appears to be a plan design issue. We haven't verified that, but it does appear that it's a plan design issue from the commercial payers. So it might drive utilization down, but it actually drives revenue up because we have to fund that in hospital rates. And so what I hear, two things, which is look at the cause of the problem and take action that's related to the cause of the problem if possible, and potentially use a dashboard approach to develop a solution to the problem. So apply the solution where the problem is occurring, or not.
I guess I would describe the dashboard as telling you where the problem is, and that'll help you identify what the cause of the problem is, and then you can address those causes.
Okay. So one of the things is that, and we can do that. One of the things that we have to have are some pre-thought solutions, because when we push the button, we usually have to act a little bit more rapidly than normally it might take 4 or 5 or 6 months to make a policy, but we actually might want to do something a little faster under certain circumstances. So so we do have to pre-think some possible causes and solutions. So I think that so we can pre-think some of those as well.
I don't know if this is on the summer vacation research list, but one thing that would be helpful is if we think about presenting data in terms of market service areas, because like politics, all healthcare is local. And think of things as a statewide is blurring where the real collaboration for a community needs to happen and the competition is happening. And so the Western Maryland hospitals are really not having anything to do with my Montgomery County hospitals and stuff, but within Montgomery County, that they need to be talking to each other. They may be competing against each other. I want to see those clustered together in reporting so that I can see, and I don't know if you have market areas defined, to share that, which hospitals are in which market areas, if they're, I'm sure there's overlap, but there should be relatively defined populations, clusters of hospitals. That would be useful for all of the policies to see how they affect the local area.
That also promotes the collaboration theme.
Yeah.
Because there's nothing like that promotes collaboration like being held jointly responsible for something.
And if we make it clear who's in which lifeboat together, that will help. I think illuminate some of these policy issues.
Donna and all, on the topic of collaboration, how can one not agree with that? Until there is a belief, and it's been maybe not said in this room, that there will end up being too many hospital beds and too many hospitals. So if you have folks in a market, let's say there are 4 hospitals in a market, and you're trying to get them to work together, but they know they're working that one of them is going out of business, that could be a tall order. Just putting it out there could be a tall order. It's easier said than done.
Oh, I get it.
Yeah.
But the reality
which is why competition, which is why, exactly. Which is why, so how do you fix it? Do you fix it through collaboration? Do you fix it through competition? Because ultimately the answer is get rid of all the fixed costs from too much capacity. I don't know how you get it done as quicker, collaboration or competition. Just a thought.
Yeah, I don't know either.
No, I don't.
Just to plug in, Performance Workgroup has been looking at some of monitoring metrics that we have in the contract and trying to come up with a higher level scorecard. And we've been discussing to not only have the state level, but some deeper geographical distinctions as well as the hospital-specific report card. We were thinking about creating a work group, small work group, just to vet those measures out once we have a template. So I think it's in our summer vacation list. So I'll appreciate if I can get some of you looking from the guardrail perspective to make sure that we have some possible needs that you may have there.
So I think the general advice is look for the cause of the problem, have some pre-vetted solutions that would lead us to look at possibly where folks haven't performed. It does. We're not. Utilization is one area that we're focused on, so that will definitely be one on our list of issues. But there may be other issues.
Yeah, the one thing I would caution us is being around a while, I remember the reasonableness of charges, work groups, and this process is like that on steroids, because you're talking about looking at utilization per population in the zip codes where there's wide disparities throughout the state. And while I agree conceptually, I think what we're talking about is going to be a very, very uphill battle to fight. Because I remember the days just when we're trying to resolve comparing charge per case, determining which hospitals were efficient and which hospitals weren't efficient. This has multiple dimensions beyond that we're talking about.
So, so basically, your optimism about a quick short-term answer for some of that is not good, and we should retain our policy in the meantime of spreading it like butter. So that's a little bit piece of advice. So your advice is it may not move along quickly, and don't dominate the staff's time in solving the problem, because we have other issues that have to be solved at the same time, and that one may not solve itself as quickly and could take us off course. We have a question from, okay, and Mac, is my understanding correct? The hospitals can be doubly penalized if volumes increase because of Medicaid expansion and then due to care shifts to unregulated settings. Both of these situations may lay outside of the hospital control, so I'm not sure how penalties can be assigned for cause in either situation. So in terms of the expansion, the global contracts actually do mention the possibility of volume expansion from reform, and that the HSCRC would measure the impact of expansion, and if in our contract with CMMI we have specifically discussed and mentioned the situation, well, what if our hospital volumes go up because of expansion? So we do have the opportunity to approach CMMI and get relief on the waiver test if volumes go up due to expansion. There are a variety of opinions about whether that will happen. One opinion is it will happen in the doctor's office and not so much in the hospital, because we've had the uncompensated care program in Maryland, which did give a lot of access in the hospital already, and we had PACT, which enrolled a lot of people, even though it didn't cover their costs outside of the emergency room. But we're only several months into it, so we don't know all the answers yet. In terms of volumes shifting outside of the hospital, the HSCRC needs to take action if volumes shift outside of the hospital, because there's certainly no savings if people pay twice for the same service by paying for it in the hospital global budget and then paying for it again in a community-based setting. So it may not be somebody's fault if the volumes move, but we can't be paying for them twice. So that's the answer to the second question. So just kind of to move to the last topic that I want to hit today is really subgroups to work on some of the topics that we have here. And we'll want to look for volunteers to help with the transfer topic, including the vetting of data. I think Michelle's not here, so I'm going to volunteer her as one of the folks to work on the transfers and the vetting of data. Are there other folks who have a particular interest in the transfers, market share topics? And obviously, everything's coming back here. I think Hank said that he has an interest in both of them. Are there others who have a particular interest in those topics? The policies are all coming back here. So we're focused on, in these work groups, we're focused on the weeds. We're going to be deep in looking at data. Yeah. And even if people don't volunteer here today, we will volunteer folks to make sure we always have balanced groups of people evaluating the issues, even in the work group. So we'll take volunteers by email. We'll probably pick up some folks who aren't on this work group who are just chomping at the bit to help us pound through data. So that'll be another source of work there. We'll also be looking for folks to continue to help us on some of the templates for the contracts, and including some folks from DHMH to help us with the, looking at the infrastructure. Do we have other comments or questions or comments from the public? So with that, we'll adjourn, and thank you for your patience. Again, we need comments back on the demographic adjustments by the end of this week, so that we can finalize that policy for the July 1 update. Thank you.